Good evening, everyone, and welcome to the Change of Shift podcast. I am your host, Sean, with my amazing co-host, Emily. Emily,
Good evening,
how are you?
Sean. I am doing well. How are you?
Well, apparently the internet and I are not communicating well today, so we will do our best with hosting our amazing guest this evening.
Mm.
Not sure what's going on from my perspective with my technical issues, but we will press on.
Keep our fingers crossed.
Yes, keep our fingers crossed. So, like every other episode, we're going to start with a quick recap of our last episode, even though for those who are watching, the post-production for our last episode has not been released. Well, we both have, full-time jobs on top of this. So every so often there's a hiccup, but nonetheless, Em, tell us about our last episode.
So our last episode, we talked about body modifications, both in our patients and in healthcare providers. We all know that the generations have changed and the viewpoint on tattoos and piercings has changed quite a lot. There's a lot of controversy that goes along with it, but we also explore quite a lot of the intricacies of how it affects our patients and our patients' lives. So on the episode, we had Sonia Grinnell, who is a tattoo artist and co-owner of her shop. And we also had James Ramir, who is a professional piercer. He's been piercing since 1993. And he also co-owns his piercing shop down on, both of them are from Michigan and happen to be friends of mine. However, with that, as goofballs as they were, and as much as it was like herding cats, I think we learned a lot, Sean.
Yeah, I was pleasantly shocked, not only by our wonderful candor, but that they taught me quite a bit about educating healthcare professionals in regards to body modifications. Because I've worked in surgery for a good part of my career, and some of the topics that we discussed never crossed my path and never crossed my mind. And now the next time that I have someone who has tattoos and or body modifications, I'm going to think twice about how I care for them. So it was very enlightening.
And with body modifications, we're talking about tattoos, piercings, and there are a lot of different things like dermal implants and other types of implants now that people are getting, and it's becoming more mainstream. And it can be dangerous. It can be dangerous to pull out jewelry. It can be dangerous if we don't know where to look for jewelry. And it also has implications for the patient's life for the rest of their lives. Sonia gave us some great examples of some of her clients who had tattoos that were ruined by careless healthcare providers.
Yeah.
So it was interesting. It was
near and dear to our hearts because the host and co-host both are tattooed nurses. So it was a little bit of personal bias, professional bias there, but a lot of great takeaway information. So we'll be excited when we finally have the time to get that up and running on the website as well as our podcast. So, okay, without further ado, we have one of the most amazing guests we've had so far. She is well-renowned. Renee and I met on Twitter, just like almost every other nurse, every other healthcare care professional that we have invited here. So social media is a powerful, powerful juggernaut. Our guest this evening is Dr. Renee Thompson. She is a nurse bullying champion. And I'm going to leave just at that right now. So I'm going to give you a little background here. Unfortunately, I'm going to be reading some word for word verbatim from her websites before we let her take away the show. So she is a nurse for more than 25 years. She's a nurse educator. She's a nurse executive. She's become one of the country's leading authorities on nurse bullying, clinical and professional competence, and nursing culture. She's an author, a keynote speaker, anti-bullying advocate, and all-around believer in good humans. I love that. I absolutely love that. And her motto, nurses should be kind, not cruel. She runs, I believe, 2 separate websites, or at least one website hub, which is named Nurses Do No Harm. And she has another website, RTConnections, and I had to look up what the RT meant, and it was kind of a no-brainer when I realized what RTConnections meant. RT as in Renee Thompson. RTConnections, and she has a blog on that website as well. She has been blogging there since 2010. She's received numerous awards for her blogging and her posts. On her main website, nursesdonoharm.com, she has lists of all of her speaking engagements. She has live seminars there. She has a consulting service. She actually has anti-bullying programs and resources, as well as previous interviews that she's had with other providers and other podcasters. And of course, she has books, ebooks, and other toolkits. And more specifically, the book that she has written, Do No Harm, applies to nurses too, strategies to protect and bully-proof yourself at work. Renee, welcome to the show.
Yay! It's great to be here.
This has been a long time coming. Renee and I have been friends on Twitter for a while, and we found out through Twitter that we actually have worked in the same area and have walked the same streets. That would be Pittsburgh, Pennsylvania.
Yep, good old Pittsburgh.
Yes. So this topic is near and dear to my heart because I am a huge advocate and supporter of the horrible notion of nurses eating their young. Mm-hmm. So I know that this is a tangent off of the main theme that you speak of. But after all that I have said, you tell us a little bit about yourself.
Okay. Well, as you said, I've been a nurse for a long time. I've pretty much done everything that you can do as a nurse. I've done a whole lot of other things that weren't listed there. And so I've really seen the delivery of healthcare from this 360-degree perspective. And I had a position. I worked for a large health system here in Western Pennsylvania. I had a corporate position, and I was asked to do develop a nurse residency program. So I decided to do some focus groups and invite some students, some former students, some preceptors, some new nurses in to, share with me what they thought would be really helpful for them to be successful when they transition into professional practice. All these nurses wanted to do was talk about how poorly the nurses treated them. All they wanted to talk about was nurse bullying. And as I sat there and I listened to their stories, it reminded me of my own stories. And it wasn't just when I was a new nurse. Really, we always say that new nurses are the most vulnerable, but, we either young, we either old, we eat in between. Nobody is actually immune to this problem. And even in a high level position, I had been the target of a pretty, let's just say, well-crafted covert bully. And so I just thought, you know what? And I actually caught myself starting to say, well, it's just kind of the way it is in nursing. And it was as if I had a mirror, that I was facing, and I saw myself starting to say that. And I thought, wait a minute, we have to stop saying that that's just the way it is in nursing, like no more. And I really loved doing what I was doing for this large company. And I had the opportunity to meet with a lot of nurses, all over the system. And I found myself in the position where I was speaking a lot, and I had such wonderful feedback. And then I thought, you know what? Other people do this for a living. Why not me? So I quit a really great job to start my own company. And I decided to dedicate my company and a lot of what I was going to offer to healthcare organizations. I really wanted to address this problem because we're hemorrhaging really good nurses. And I just can't sit back and say, well, that's just the way it is anymore. So, yeah, that's kind of how I started all of this.
I love the term you used, hemorrhaging, because my co-host has used that term a couple times.
Really? Yeah.
So,
yeah. Well, and it's an amazing visual. I think as nurses, once you've seen someone truly hemorrhaging, it's something you panic over, or inside you panic over, outside you don't, obviously, but that's the level of a concern that we should have.
Oh, absolutely. I always, when I start a keynote on bullying or any talk on bullying, I always start out by saying 60% of all new nurses quit their first job within the first 6 months due to the bad behavior of their coworkers. 48% of newly graduating nurses, right now, it's a newer study that just came out, are afraid that they're going to become the target of workplace bullying. And every day of my life, a nurse reaches out to me asking for help. This morning, every morning I wake up and I have at least 1 or 2 emails where somebody goes through my website and contacts me asking for help. This one, it was the boyfriend of a nurse, and the nurse is being bullied, and what he described, I mean, it borderline's criminal. I mean, it's horrible. And he's trying to help her, and she doesn't know what to do, and she's kind of shutting down to the point where I'm concerned. Like, I'm really concerned about her mental health. And so I said, please get her some help. I mean, every day I get this. So we're hemorrhaging the really good nurses. And so what we're left with are the ones that are, causing a lot of the problems. So it's sad, but I think there's enough of us who get it, that we recognize that the only way that we are really going to be able to articulate our value as nurses is to join together and support each other and nurture each other and try to help each other. So.
Well, and I know this is something that Sean has talked about multiple times in our short podcasting life already. And I come from a very hard-headed, military background, but even after my active duty time, I've had not one, but 2 instances, once as a brand new nurse and the other as a brand new flight nurse, in which I was taken to the point of tears and ready to quit both of those jobs because of bullying. And, the condonement of it from management never ceases to amaze me.
Well, managers use silence as a strategy. That's one of the reasons why it continues. And, when you think about it, though, 85% of a manager's time is spent dealing with the behavior of their employees. But we don't teach managers how to deal with the behaviors of their employees. So, they'll have somebody who's been, behaving badly for years, and a new manager comes into that environment and says, what can I do? She'll retaliate against me and make my life a living hell.
And we actually talked about that in a previous podcast, how we don't teach our managers to manage. They just kind of get plopped into the position because they were there long enough and they were next in line, or they were the one that said, sure, I'll do it. And that's kind of how you become a manager. And most good managers, it's, trial by fire. You get thrown in the pool and let's see if you can swim kind of thing. And it's not a way to resuscitate a profession. That's a way of destroying it. So,
well, and it's putting them in management positions versus teaching them to be leaders. And we need to, that's one of my big, is the lack of leadership training.
So Renee, I know that we all 3 could sit here and discuss in very great detail about your passion, but I want to rewind just a little bit.
Yeah.
And you talk about 25 years of nursing. Give me a brief summary of where you've been.
Oh my gosh. Okay. Started out cardiac trauma step down for about 4 or 5 years. And then I became a home care nurse. My kids were young and I wanted to be with them and every other weekend and holiday. So somebody said, you should be a home care nurse. Well, I tell you what, it really helped me to see delivery of care beyond the 4 walls of the hospital. Because when I started working as a home care nurse, I had the fortunate opportunity to care for some of the same patients who I cared for on the inpatient side. And I'd go to their house and I'd say, no wonder you keep coming back in, because you'd see how they lived. And then it gave me that appreciation for spending the time with these patients before they go home to make sure that they have everything that they need to actually go home and successfully continue to care for themselves. So, and I fell in love with my patients. You become family when you see them, for years. So I was a home care nurse for a while, and then, don't be mad, don't hate me, but I was lured over to the dark side and I started working for a managed care company.
The
insurance company, but as I was a nurse liaison. So I was hired to go in and support our physician practices and our hospitals to help them with identifying patients who had our insurance who could benefit from some of the programs that we had, like complex case management. I ran a heart failure program, a COPD program. So I did that for a while and I really enjoyed that. So then they changed my job. Of course, you know, when you really like something that you're doing, they changed my job and I started to do some on-site utilization. Mm-hmm. So I was the chart police. I'd go into the hospitals and I would say, help me to understand why this patient's still here. They don't meet the criteria for continued stay and blah, blah, blah. So I did not like that role, but I learned a lot. I learned a lot about what delays in care can do and the importance of making sure if the patient's supposed to be NPO for a test, that they really are NPO for a test so that they can get the test done so they're not there an extra day. So I did that for a while, but then I really missed being around patients. And I had started in a master's program, master's in education, and I wanted to teach. So I tried to get back into the acute care setting through the education department, but because I didn't have a master's yet, they said, well, you don't have your master's yet, but we have these great unit director positions. So I became a unit director on a 35-bed. They chewed me up and spat me out. It was horrible.
Yeah.
It was rough. Again, I learned a lot. And I was there for about 1.5 years, and I was in a master's program. I was going through a divorce, and I needed to take a step down from that. So I got involved in neuro. So I went and started working on a neuro step-down unit in the same hospital. Did that for a while, got involved in stroke care, finished my master's, went to a sister hospital, and I was an educator there, and then became stroke coordinator. So I was stroke coordinator for one of the large hospitals here in Pittsburgh, and then got the corporate position from there, and then quit. Yeah, start this company. So
I love the fact that every step of your career, you didn't say anything negative. You said you learned something.
Oh my! Oh yeah!
I love that. So thank you and kudos to you for that. And that was something that looked like you had to say. You truly are genuine about the fact that you may not have really liked the position, but it molded you and it educated you.
Oh, they were all gifts. They were all gifts. If you look at the experiences that we have, the good, bad, and even the ugly, if you see them as gifts, that what can you learn from this is going to help you to be better in the next role that you have, because I would not be able to connect with my audience like I connect with them now if I didn't have all of those experiences.
Amazing.
Yep. Good stuff.
Wow.
So let's rewind one more step.
Yeah.
Why nursing?
Well, in the keynote that I did, this one keynote presentation titled Celebrate Nursing, Human by Birth, Hero by Choice. And I started out by saying, why did you choose nursing? I mean, you had other options. Why did you choose to become a nurse? And I always say that I choose nursing for 2 reasons. One is I'm still I love science. I love the human body. I'm still fascinated by I still even, working, 12-hour shift, I'd come home and I'd put on the Discovery Health channel, trauma and the ER, mystery diagnosis, trying to figure out what's going on. Think about the pH of your blood. I mean, 7.35 to 7.45. Anything above or below and you're dead. How aren't we all dead? I mean, I'm just fascinated by the human body. And the second reason that I chose to become a nurse was, for many of us, it's the same. I wanted to make a difference in the lives of other people. Yeah. And I thought, you know what, this is the best decision, the best choice to enable me to, continue with my passion for the human body and my interest and curiosity and, make a difference. So that's why I chose nursing.
So you already touched on it earlier when you talked about you had your own experience in regards to bullying, which kind of was the impetus for developing the company that you now run. But bullying is an umbrella term sometimes, because when I think of bullying, I grew up in a ghetto. So when I think of bullying, I think of physical violence.
Sure.
But you also have the lateral violence, which we do speak of mostly when it comes to nurses eating their young. Yeah. But we also have what is probably the bane of my existence is the passive aggressive behavior.
Oh, you must be talking about women.
No.
Sorry.
Well, sorry. No, I mean,
I do a whole
So the reality is that, you know, Emily and I have actually joked about it that, you know, she's, without offending anyone, she's a guy. If her and I have a disagreement, her and I lash out at each other, swear, scream, kick, maybe even cry. But once it's out, and we move on. And Emily and I have known each other for many years, and this is a partnership we're having, and we've already hit a couple bumps to the point where we came out swinging, and it was, you get it out, it's over. What happened? It's over, you know? So tell me why all of that is under one umbrella. Why is it that passive aggressiveness, physical harm, emotional baggage, or emotional, you know, challenges, why is all that considered to be under one umbrella?
Yeah, because it's easy to label something as one thing, bullying. And I've written a blog post about this, I think more than one. And I talk about this a lot in some of the seminars that I do. Not everything is bullying. We label bullying anything, somebody's rude to us. Oh, you're bullying me. If a manager, say they are trying to hold a staff member accountable for coming to work on time, that staff might say, oh, you're bullying me because, you know, you're yelling at me. Not everything is bullying. So I talk a lot about the definition of bullying, and for it to be truly a bullying situation, it has to be repeated behavior. So my definition of bullying, which is pretty standard, you know, globally, is that it's the repeated patterns of destructive behavior with a conscious or unconscious attempt to do harm. So just, you know, and I say this a lot, you know, how do you know if your coworker is a bully or a drama queen or a jerk or just having a bad day? Because let's say, you know, you're in a situation, and Emily, I'm sure you're in this situation frequently. You're a flight nurse, you know, you're dealing with life and death situations. Sometimes we're not always that nice to each other in the crisis moment. You know, people can get testy with each other.
Yep.
But you're not all bullies. So, you know, I always say that the stressful environments that nurses work in set us up to get testy with each other. But we're not all, you know, bullies, and it's not all bullying. So what you're looking for is this repeated pattern of behavior. And there's a couple of different forms of it, because it can be physical violence, and that could be a form of bullying. It could be the passive aggressive behavior. So what you're looking for, and what I try to teach people as a way to start taking a look at strategies to eliminate it, is singling out the behavior itself. And if you look at human behavior, you can categorize behavior into two different categories. It's overt and covert. So somebody hitting you, screaming at you, that's overt. So everybody can see it. Everybody can describe it the same way. Somebody threatening you, that's overt behavior. Covert is the passive aggressive. I'm so nice to your face, and as soon as you turn around, I'm going to find a way to stab you in the back. Or I'm going to spread false rumors about you. I'm going to say things about you that aren't true. But in front of you, I'm like, oh my gosh, somebody said that? No kidding. I mean, you would not believe the stories that I've heard from people. I had a nurse tell me she was, it was 2:00 in the morning. She was sitting at the nurse's station documenting on the computer. And this other nurse walked up to her. She said, that's my computer. You're in my chair. Get out of my chair. And this nurse said, oh, I'm sorry. I'm almost finished. I'll get out in just a minute. It's like, I said, get out of my chair. It's like, seriously, just give me one more minute. And she took a cup of water and threw it in her face. Yeah.
At work?
At work. Threw a cup of water at her face. And then she ended up, and so I said, well, what happened? Nothing. Do you know why? Nobody said anything. Nobody documented it. It's 2:00 in the morning.
The documentation piece is what kills me.
Huge. And, you know, when I was a manager, I would have some of my staff come to me and complain about behavior of their coworkers. And I would say, oh, can you please document this? Oh, I'm not documenting it. She'll
and
find
why?
out.
Why?
They're afraid that they're going to find out and retaliate against them. Oh, yeah.
I've had numerous conversations, and not just about bullying, but so many conversations with staff members about issues that they've been having in one way, shape, or form. And the lack of documentation is what has led to a seeming lack of ability for management to do anything about certain things.
Absolutely. Documentation is power. Documentation, especially, and I do a whole section on how to document. And what I tell nurses to do is, chances are, if you're in a bullying situation, so somebody's really, you're a target, chances are you're not the only one. Chances are there may have been somebody before you who now you come along. Now the focus is shifted onto you. Get together with your group and document together, like build a case. I just wrote a blog post that actually got a lot of attention called How to Catch a Professional Bully. And these are the people that kind of hover under the radar. They're usually very passive aggressive. They're great in front of management. They're usually clinically competent. I mean, excellent, but everybody knows they're toxic. And, you have to join forces and you have to build a case. And there's so much more power in more than one of you documenting. So if everybody's documenting and you're documenting similar behaviors, you're demonstrating a pattern, and human resources can usually then do something about the situation.
So what advice do you give to nurses who come to you and talk to you about situations? Do you, other than the documentation, I mean, what does it usually take for them to take that next step and really stand up and say, and start throwing some flags and saying, no, I really do need some help and I need somebody to address this? Because I know in so many situations that, I've seen instances where people would go to their manager, but they were afraid to go to HR.
Exactly. It takes courage. It really does. And I talk a lot about confronting these people. And confronting doesn't have to be you walk up to that person and say, okay, you're screaming and yelling at me. You need to stop right now. I'm done. I'm not taking this anymore. It doesn't have to be that grandiose. It can just be them coming to me and talking to me about it. The first step is speaking up. First of all, I guess before that, you have to recognize that this behavior is inappropriate, that the behavior is unprofessional, because sometimes people who are, especially passive aggressive people, are very subtle in how they start their, and I don't want to say that they're bullying, but they start making you question your competence. They start making you question, because let's say somebody says something, a racial slur, ethnic joke, something like that, and you get offended and you say, I'm offended by that. Oh, you need to lighten up a little bit. I was just kidding around. Like, seriously, like, you need to lighten up. You might start thinking, well, maybe I do need to lighten up a little bit. Okay. So they can talk you into downplaying their behavior. So the first step is to recognize this behavior is unprofessional, inappropriate, does not belong in healthcare. The second then is to really speak up and start talking to people about it. See, we use silence as a strategy, but yet so many of us are suffering in silence. One of the things that we can do is to start having a voice and start talking about your experiences with other nurses, with the educators, with your preceptor, with people outside of the organization, just to, first of all, get it off your chest and to get some validation that you're not crazy. This is inappropriate. And then you can start getting some support to actually maybe be able to confront, to be able to name it. Like, I just saw you roll your eyes at me. When I asked you and this is a common thing that happens, a nurse will leave this, the end of her shift. She'll give report to a seasoned nurse. She'll maybe leave some things undone. That seasoned nurse will say, go ahead home, honey. It'll be fine. I've got 12 hours to, pick up the slack. And then as soon as that nurse leaves, they're bad mouthing them. You know what I mean? Oh my God, she left me a mess. And so to go to that nurse and say, when I left here yesterday, you said everything was fine. To go home, that you would pick up the slack. So you're using their words. But then when I left here, I found out that you were talking about me behind my back. If there's anything that you have a problem with, I'd like you to come to me as a professional. I wish, I'd like you to come to me first. So it's those kinds of conversations that you can start helping them to build towards, because nobody's going to, well, I shouldn't say nobody, but a lot of nurses are petrified to speak up. Mm-hmm. And, and the whole documentation. So it's date, time, witness, verbatim comments. And here's the other tip. Anytime you can link somebody's behavior to a patient safety issue, you have a greater chance of having somebody do something about it. Strategic goal, organizational goal,
wow,
patient outcome. Yeah. And I've got plenty of examples of how behavior impacts patient outcomes.
Wow, that's something that had never crossed my mind.
Yeah, I'm telling you, me and Time Warner, we're gonna have a talking
go round.
So, I hate to go off topic, but this is the reason. This is another supportive evidence to why you have to have a co-host.
Yep.
Yeah.
So, right there.
Emily.
Yeah. So I know. I don't think I didn't miss. I caught on to what you were discussing in the little bit that I did miss, and ironically, the closing piece of tying that to patient safety. I actually give that advice to other nurses who have come to me, and I actually use that as a I don't want to use it as the term bargaining tool, but I use it as a way of bringing attention so that somebody has to address it.
Oh, yeah. Well, you probably know this. In 2008, the Joint Commission, came out with the Sentinel Alert that basically said every healthcare organization has to have a policy in place to address formal complaints of disruptive behavior that undermine a culture of safety. Mm-hmm. So I always tell nurses, use the language that HR has to use in the policy. Mm-hmm. So if you want to go, so you spend a couple of weeks documenting, and then what you do is you schedule an appointment with your manager, HR, and you say, I want to file a formal complaint. I have 6 weeks of documentation that demonstrate these behaviors that undermine a culture of safety. So you use the language, and they're bound by that, or you could report them to the Joint Commission. So, a lot of people who are being bullied feel like they're victims and they don't have any control over their situation. And what I try to do is help them to realize that they're not victims. They're targets. They're targeted, but they're not victims. And there's things that they can do. And, to start flow, to start just by talking to people about it. I always say you can't swing the pendulum from over here all the way up, but maybe you could start nudging it a little bit this way. You know what I mean? Just start engaging in conversations about it.
So I just thought of this because I'm thinking in terms of my own experiences, is that I have more of my, umbrella bullying experience is with passive aggressiveness. Yeah. And do you find in your experience that because I'm a male nurse versus, the female coworkers or vice versa, that, I don't have anyone, and I'm speaking in general terms from nurses to physician partners. I don't have anyone who screams, yells. Most of the bullying I have has always been covert, not overt.
Yep.
Now, am I making that up, or
Nope.
Is that something that is common?
Very common. So I actually do a lot of work teaching communication skills. And there's 4 different types of communication styles, aggressive, passive, passive-aggressive, and assertive. And we all have our own natural style. Women in particular, more women use the passive-aggressive communication style. And I always say, no matter what your natural communication style is, the only style you should be using in healthcare is the assertive style. The assertive style says this: how do I have a conversation with this person that's both honest and respectful at the same time? That's assertive, okay? Aggressive, they're in your face. Passive, they just don't say anything. Passive aggressive, they don't say anything, but then they get you back, kind of a thing. Since passive aggressive communication style is more common in women, and Sean, let's face it, the nursing profession, we're a female-dominated profession. 90% of us are women.
Yeah. And I recognize that, and it's not either good or bad. It just is.
It's a fact.
Yeah.
And when I talk about why is it so why is bullying so prevalent in the nursing profession, I talk about the female-dominated profession, and I always say, let's face it, ladies, we're not that nice to each other now, are we? It really wasn't all that long ago that we were competing against each other for the prized male to, marry the lawyer, the doctor, the banker. And how did we do that? We did that by squashing other women, making them look bad. Well, you fast forward to today, and women are the bankers, the lawyers, the doctors, yet we still haven't let go of those squashing tendencies. And, we've been talking about, my blog, I've been mentioning it. The blog post that I wrote that had the highest views of any blog post that I wrote was one called The Number One Sin Causing Nurse Bullying. And it's all about envy, jealousy, women not wanting other women to get more than they have. And what they do is they single out people and they target them. And sometimes women do this to men because they're threatened by certain people. They have this level of insecurity about them. And the passive aggressive communication style, people who use this style, they don't feel that they have the power to address you directly. So they find a way to address you indirectly or the situation indirectly. And, it's probably the communication style that causes the most toxicity in an organization, and the covert bullying that I encountered, even at a higher level, I didn't know this person was doing this, sabotaging me for 2 years. 2 years.
Wow.
Mm-hmm. Until I got to the point where I was really questioning my competence, thinking there was something wrong with me and that I wasn't as good as I really thought I was. And who did I think I was? And then I found that it was all her undermining everything that I was doing.
Yeah.
Wow.
Yeah.
Well, and it's amazing that it happens on so many different levels. And
Yep.
And sometimes I wonder, well, and I'll just ask you, how many times do the bullies really know that that's what they're doing? I know that there's a truly evil person in this world, but how many times do people who are bullies really understand what they're doing to other people?
Yeah, that's a great question, Emily. I talk about what happens when you confront somebody who's bullying. And I always say there's 3 outcomes. The first outcome is, and when you confront, you say something to them, you're honest and respectful. So, I'm not sure you realize this, but sometimes you can come across as being very aggressive or intimidating or threatening or whatever it is. The first reaction, the type of reaction you might get is, I don't mean to come across that way. That's not my intent. Like, I didn't realize I was coming across this way. Every time I do, especially my full day bullying seminars, I always have somebody come up to me who will say, I think I'm a bully.
Wow.
I had this one woman, oh my, she stood up in the back of the room and she said, I'm a bully. Her coworkers were next to her saying, no, you're not. No, you're not. It's like, no, I am. No, really? It's like, no, I am. They said, okay, yeah, you are.
Wow.
I hugged her. I went back. I hugged her. She cried. I cried. Everybody was crying. I tell you what, when somebody has that realization, they can turn the mirror on themselves and they see themselves through other people's eyes. That's a gift. That is somebody that you absolutely want to work with. It's somebody who's, they think they're coming across as being assertive, but the reality is they're coming across as being aggressive. Okay. They think they're taking charge and getting things done, but yet they're attacking people. That's the group that I love to work with. The second group is these people have got issues, like mental health issues. 25% of all human beings are not mentally healthy. Have you noticed that we're dealing more and more with mental health issues in healthcare? And so we say, mental health issues of our patients, their family members, and our coworkers too. So these are people that need professional help. They've got big time problems at home. They've got alcoholism. They've got drug problems. They've got something. And I don't know that you're going to be able to help them. You need to bring in EAP or some other resource. And then there's the last category. And this is sort of the category that you were talking about. These are people who are not willing to accept any responsibility and have no sense of self-awareness, even when you spell it out for them. No sense of self-awareness. They don't want to take responsibility. And this is what you do with these people. You don't work with them. You fire them. You find a way to fire them. Now, the good news is those people, the truly evil people, only represent about 3% of anybody in any company, about 3%. When you find them, figure out what you have to do to fire them. You don't work with them.
And that sounds very, very black and white.
Yep. It is.
And thinking over my 20 years in and out of healthcare, I can see hindsight's 20/20, but when you're in the middle of it, that's very difficult. I can't imagine it. How do you train a leader or a manager to differentiate?
It's hard, but what you're looking for, again, is remember, you're looking for patterns of behavior. You're looking for a history. And, I always talk about you have to build a case. So anybody can have, anybody can go through tough times, and they can have depression, and they can have family problems that seep into the workplace. We all know that. But I challenge everyone to think about that one person in their company or on their unit that they know is pure evil and toxic. Those are the people that I'm talking about. Those are the people, and like I said, they tend to be clinically excellent at what they do. Mm-hmm. But they're the ones that, and I always say this, let's say you're an experienced nurse and you're watching a new nurse about to make a mistake. The new nurse the person standing there sees that and says, oh, wait a minute, stops them from making a mistake with a patient. Some of these toxic people, instead of stopping them from making the mistake, say to their coworker, oh, watch this, and stand back and watch them drown, watch them make mistakes, knowing that patient care is being affected.
Yeah.
These are the
unfortunately I've experienced all that
responsibility to the public. Mm-hmm. To remove them. If you're not going to change, and these people probably will not change, you have to remove them.
So here's another question for you. What do you do when it's management?
Yes.
That's the issue.
I was waiting for that question to come up.
Oh, look. Look at it. This is great. I love it.
Yeah. You know what? I wrote a post called "What if the bully's your boss?" and it got picked up by a couple of other online, journals, and this one group picked it up, and within 24 hours, I had about 47 emails from nurses telling me that was their story. It's the boss. So I don't lie. I don't try to pretend like there's always a solution to everything. Because I always say, confronting might not work. It might not. You could do all the things I'm telling you to do and you still might have a problem. But I guarantee not confronting never works. Okay, so we got to try something. But when it comes to the situation where the boss is the bully, it's much, much harder. Especially if that boss is friends with their boss and their boss. And I have actually recommended, so I got to hear the story when a nurse comes to me and says, my manager is the bully. I, find out what are some things that this manager's doing. What have you done? Have you had a conversation with her? Give me the background. When I find out that the manager is best friends with the clinical director and they're best friends with the chief nursing officer, you know what I tell the nurse to do? Leave.
Quit.
Get out of there.
Leave.
Get out of there.
Get out. And people say, well, then you let the bullies win. Let them win. Okay. It's not worth your health. It really is not. So the same principles apply, though. You start documenting it. You try to get other people on your department or your unit to collaborate with you on, is this what you're experiencing too? You can file a formal complaint. You can do all those things, but it's really much more difficult when the bully's your boss.
And I truly believe that the 60% that you talk about that quit after the first year of nursing are those nurses that go on to that small unit, that small hospital, and everybody knows everybody, they're best friends with everybody, and it goes up the ladder. And they try to correct the problem by addressing it or speaking to their manager or speaking to the manager's manager or so on and so forth. But I mean, the best term I can use is, you can't penetrate the boys club no matter what you do. So they quit. And I think that is one of the main reasons that 60% exists, because at the heart of our profession, it's, there's a majority of people that got in this profession because of somebody they knew.
Yep.
Or somebody they interacted with. So it's kind of a rollover effect that you usually end up at the same hospital or in the same unit,
Sure.
and you're all the same friends. So unless you're part of the clique, you get pushed out. Unless, unless the top hen likes you, they make your life miserable.
Oh yeah. There's a whole way that bullies treat new people, and some people, even if they've been on unit for a while, they use exclusion. Exclusion is a powerful weapon that they use. So you're either in the club or you're out of the club. I was talking to somebody who said there was this little gang of nurse bullies, and they all wore certain barrettes in their hair. So if you were in the club, in the gang, you had the barrette. And if
anyone ever seen the movie Heathers?
Seriously, I'm like, are we 12 years old? Like, oh my gosh, unbelievable. But yeah, these are adult women, behaving and,
I always use that. I say that out loud. I do. I say it out loud to my boss, to my physician coworkers, to my nurses. Are we in high school?
Yeah.
Didn't we all graduate? I mean, can we have a discussion like adults?
Yeah. So. It's really sad because, and you've probably heard the Gallup, surveys that they look at. The number one reason why somebody stays or leaves their organization is the relationship that they have with their boss. The second reason is whether or not they feel a sense of belonging. And when you think about these are social reasons. It have nothing to do with how much money, where you work, what type of, patients you care for. These are all social reasons. And if you are new and you start working in a unit or department that you don't feel supported, especially by your boss or your coworkers, like you can almost handle physicians being nasty to you if your boss is supportive and the people who you're working with are supportive. But they'll leave, because human beings are social beings, and yeah, it's really sad.
Yeah. All right. So we're going to try and stay on topic here. So one last question I want to ask, since we are focusing on the bullying, is that I want you to think of the most important element from your entire, the entire reason why you created your company.
Mm-hmm.
What is the one thing you want to convey about bullying to the new nurse?
Yep.
And the same thing to the seasoned nurse. One thing that may be the take-home message.
Just one. Well,
I'm going
to give you one for the new nurse.
Okay.
Because all the research I did in my doctoral program was to help that new nurse protect and bully-proof him or herself when they start their first job. It's to recognize that this behavior's out there, be prepared for it, and be confident in yourself. Because what bullies tend to look for are people who don't display this level of confidence. And I think as nurses, we have to start articulating our value. Whether you're new, whether you're an older nurse, we have to articulate it to our public. We have to articulate it to our colleagues, to our physicians. And when you can actually then believe that you provide a valuable, I don't even want to say service, but it's about recognizing the value that you do bring to patient care, whether you're young or old. I think kind of gives you this little bit of an invisible force field around you, because a lot of people like to pick on people who look like they don't have high self-esteem and that they're not confident. So even though that you're new, you walk in there with your head held high and your shoulders back, and admit when you don't know something, but just say, no, I'm capable. I'm going to learn this. And when you're an experienced nurse and somebody starts treating you like you're an idiot, stand tall and say, no, I'm not an idiot. I just don't know this thing. Okay. Because we all have the capacity of continued learning. And so it's just, I guess that was one thing, wasn't it? Sort of. It's being confident.
It was one very good
being
thing.
confident in yourself, no matter what. And just recognize that you don't know everything. You'll never know everything, but to just believe in yourself. You know, don't let anybody steal your dreams from you, because I can't stand it. These poor nurses, they suffer and get through nursing school, and then they start working in some of these toxic environments, and then they leave us. You know, these are people who've always wanted to be nurses. It's really sad.
Well, and we all know how difficult nursing school is.
I know, it's grueling.
And you get through that part and you think, oh, good, I've made it. And then you're trying to learn and actually become a nurse, and dealing with those pressures on top of it, it's completely overwhelming.
It is, I know.
Very overwhelming. And heaven forbid we talk about, dealing with all the difficult things that related to our patients and death. And
yeah, I mean, we deal with life and death, but, again, we have the opportunity to make such a positive difference in the lives of these patients. I mean, you hate to say we're all going to die, but it is true. And it's a privilege to be there with these patients in that moment, and to help them transition into the next life in a more peaceful way. And, and then to support the family members. I'm about supporting the families as much as I am about supporting the patients. And I don't know that we talked about this, but I still practice at the bedside. I still work. Yeah, a couple days a month, because I have to be in the weeds with them. I have to know what they're going through, so I can say, oh, no, I know this just happened to me last week. So, in order for me to help nurses, I have to know what they're going through. So, yep, a couple of days.
Wow.
I work on a med-surg observation unit right now. So,
huge respect to you for doing that. It's one of my big concerns, especially in leadership roles in nursing, that at a certain point, so many that get away from the bedside for too long forget, or things change so much that they just don't know.
They do. And so, like, I still teach clinical courses. I do certification review courses. Somebody just asked me to teach a neuro course. I mean, I was a stroke coordinator, so I know neuro very well. Well, I can't be teaching clinical topics if I'm not still clinical. I can't be, sharing my stories from, 10, 20 years ago. So I had to, make a decision. What am I going to do? If I really want to be the best that I can be, I got to go back. And I did. It was the hardest thing I've ever had to do. But
I bet.
So I've been back in practice now for about a little over 2 years. Yeah, I love it. Love it.
Wow. So as Sean asked, what advice would you give to the seasoned nurse, and or let's change it up a little bit, the new nurse manager?
Oh gosh, the new nurse manager. Well, it's about setting for the new nurse manager, and I do work with new nurse managers. It's about setting behavioral expectations. You have to tell people how to behave. Like, you have to set expectations. You cannot assume things, and you have to say, okay, we're all going to start treating each other with respect and in a professional manner. And then you have to ask your employees to identify what that looks like, because people have a different idea of what respectful behavior looks like. You can't assume people all know that. So it's about setting behavioral expectations up front, and then holding people accountable for those behaviors. And, I've said many times, I've had managers come to me and say, I'm dealing with this bully, nobody's been able to catch her. I don't know what to do. And I'll say, you sit down and you say, look, I know you've been doing this. I might not have it documented right now, but you need to know I know. And I'm going to be watching you. And this is what I need you to do. I never want you to do this again. Can I count on you? This is what I want you to do. Can I count on you? And you get them to give you a verbal commitment. It's kind of like a Jedi mind trick. If I ask you, Emily, I never want you to say blah again. Can I count on you? And you say, oh, yes, you can count on me. It's a Jedi mind trick.
It almost sounds like passive-aggressive behavior.
I can only do this stuff for good. Only.
Okay, Glenda.
For badness. And what I would say to the experienced nurses is, you need to protect these new nurses. You need to protect your coworkers. You need to protect anybody who walks onto that unit from these bullies. You have to protect them. That's our job. We have an ethical responsibility to protect our public and to protect each other from some of these toxic human beings.
Before I get bumped off because of my wonderful internet connection, I had a thought. You were talking about having the new nurse show up with with confidence in themselves.
Yes.
And I'm wondering, maybe that's why the old bitty burned out seasoned nurses think that the newer generation is cocky.
Oh, they are.
Wow. Because when, Nurse Ratchet, who still is practicing right now, when they started, they were yes doctor, no doctor, yes sir, and it was a very
my chair doctor.
Yes, here, yes. So that's the way that was the environment they grew up in, and that you had to earn your stripes, you had to earn the chair to sit down, and nowadays we teach them from the start that you are a valued member of this team. I don't care if that physician has 20 years of surgical trauma experience. If you have something to say about your patient, say it. And these older nurses, or even the older physicians, anyone in the healthcare team that has been here for more than 20 plus years, maybe that's why they view it that way, is that we want our newer nurses to have that kind of, I mean, confidence, I guess, is the best term, but it's the advocacy that we want them to have for our patients. Is that even though you are going to be scared out of your britches and your voice is going to tremble, you need to speak up for yourself and your patient.
It's a topic that I discuss a lot with people about this newest generation of nurses coming into the workplace, that they have this higher sense of self-confidence and ability than they really do. I always say they come into the workplace, they think they're all that in a bag of chips. They think hey, I graduated, I should be charge nurse in 3 months, and I should have all these things. And the experienced nurses are like, honey, you need to pay your dues. Mm-hmm. And so there is that level of some of them are overconfident. Mm-hmm. But there's a difference between being confident and humble to say, I'm confident that I can learn this, but I need your help to do that.
Yeah.
And coming in saying, I'm confident, I don't need you, I can do this on my own. And I think that people who are, I'm confident I can do this on my own, may get targeted by some of the experienced nurses. Yeah. And because a lot of them do complain that and there's this whole new generation of nurse bullies, the ones who do come in, they think they're all that in a bag of chips, and they start bullying the experienced nurses because we're not as up on the technology, we're not as fast as them. I get a lot of emails from older nurses who are saying these newer nurses are pushing them out. So again, if you just look at the behavior and you identify what the behavior is and address the behavior, it doesn't matter if you're new, middle-aged, older, it needs to be addressed.
I think that's what I love that you said earlier, is that you always end up spinning it, and spin's a bad word, but you spin it so that it reflects patient care. And yeah. I always use that in every instance at the bedside with new, old, seasoned nurses who have been doing this for 20 years show up on my unit for the first time. Is it benefiting the patient? That's all I want to know. Is it going to harm, hurt, or help my patient? That's ultimately what is going on. Is the practice, is this behavior helping the care of my patient? I don't really give a hoot about where you've been, what you've done, what you've earned, how many certifications you have. Right. If you're not benefiting my patient, get away. Mm-hmm. So,
that's a good point, Sean, because I do a lot with scripting, and I teach new nurses scripts. Well, any nurse scripts to say in response to certain, things that nasty people say. And one of them, a few of them, I always end up saying, okay, that's fine, but how does this affect the patient? What does that have to do with our patients today? What's best for our patients? And to say it as a way of our patients, because I can't stand it when some nurses look at this as these are my patients on my unit, on my shift, instead of taking a step back saying, wait a minute, we're all here together to collectively care for these patients. So, if you can link it back to a patient safety issue, but then in the moment, link it to a patient care, opportunity. I love that. So thank you.
Yeah. Any final words from either one of you in regards to bullying that you want our audience and listeners to remember or think about?
I will give you one. A lot of nurses think when they're exposed to bad behavior that if they just stay quiet, they're not contributing to it. And, they say, silence is golden, right? But in the case of disruptive behavior and bullying, gossip, any of these things, silence is not golden. It's an agreement. So I think we just have to stop using silence as a strategy because it's not working. So I'm asking everybody on the call to start speaking up. If they're not going to speak up to the person who's behaving that way, speak up to someone. Start talking about it because we have to start engaging in conversations about bad behavior. So, and thank you for the opportunity to be on this podcast, Sean and Emily.
Oh,
wow. Renee, thank you. You've dug some stuff into the back of my brain that I
Emily and I have quite a habit going on, and I must tell you that she was almost jumping out of her chair because she really wanted to just go off and ask you a gazillion questions, and she behaved. So I give her kudos because this also was a very passionate topic for her. So,
and one I've dealt with very recently. I think the biggest thing I'm taking away from the things you've taught us tonight are, number one, that doing the right thing is not the easy thing. Number two, because I am one of the more senior nurses currently where I work, but also, starting in a new position as a nurse practitioner, that I will be in a different position and I need to really keep my eyes and ears open. Because if we don't take care of each other, nobody else is going to do it. And I'm grateful that, thank you for the reinforcement that I feel like professionally and ethically have done the right things. So, and it's hard to do. It's so hard to do. My gosh.
It really does. But I always, before, there have been times where even now I'm in a situation where somebody's yelling at me or a family member, and I'm like, okay, I'm supposed to be the expert in this. What do? I do the pause and I think, all right, how do I have a conversation with this person that's honest and respectful at the same time? Because you never want to retaliate. You never want to do that, tit for tat. You always want to be the role model for professional behavior. And even if in the past you've had a situation where you weren't, it's okay. You learn from it and you move forward. But I just think, what's my ethical responsibility in this situation? And trying to make the best decision at that time.
And what can we take away from your career is that, yes, everything hard, good, bad, and different. You walk away knowing that you've learned a lot. And I will think about that every time I take on a new role. Yeah. And as I speak about my career, as Sean said, spinning it, but being very honest about that. That's, I think the way we speak about our profession says a lot as well. And I appreciate that example from you. That's
very inspiring. Absolutely.
Yeah. Thank you. That's very what inspiring. I was looking for, John. Very inspiring.
So Renee, are you on a time schedule? Are you awake enough, or do you have to get going?
An hour past my bedtime.
Yeah. So let me wrap things up here, and we'll shut off the record button for those of our listeners who subscribe either by watching the video or eventually when this gets on to the syndication with our podcast. We're still working on it. Trust me, we're still working on it. You can find us out on the web, of course. All you have to do is Google The Change of Shift. And we are at thechangeofshift.com on our main website. We're on Facebook, obviously The Change of Shift. You can find us out on Twitter, Ask the Cause, ASKTAF, Ask the Cause. We're also on YouTube and Google+, the same moniker, The Change of Shift. We have, ironically, we finally have a logo, thankfully. It took a while. It took a lot of sweat on my part, but we finally have our own logo. So check it out and let us know how you like it, how you not like it. Our little, what did we call it? Sexless? Is that the term we're using? Are we calling it, or unisex? Sexless, our little figure is sexless, and it was on purpose because genderless. Thank you. I like that.
Bailing us out, Pammy. Thank you.
We have our wonderful friend Nurse Pammy bailing us out. So it's genderless, and that was on purpose because guess what? Our profession should be genderless. Is that I'm not a male nurse. I'm simply a nurse. That's right. And these fine young women are not female nurses. They are just nurses. So any parting words, Em?
Nope. Yet again, Sean, another great evening.
Amazing. Absolutely.
Thank you. Safe travels.
Yeah.
Yes. So, and as always, what do we always say?
Make sure you check your own
pulse first.